For today's conference. So this is a case conference. We have a patient the ER is getting ready to admit. I will read off the HPI to you. You're going to be the admitting resident who's going to take care of this patient. So he's a 63-year-old retired personal training consultant. He has a diagnosis of prostate cancer with metastatic disease to his bones and lymph nodes on bicalutamide. He has a history of a T2 through 6 posterior spinal fusion and a T4 radiofrequency ablation, followed by spine clinic. He's coming in with acute on chronic thoracic spine and chest pain. He states that he had his baseline T-spine pain and chest pain, but when he woke up today, the pain was more acute and more severe. He has no dyspnea exertion, no exertional chest pain, no cough, no hemoptysis, no feverish chills, and says the pain feels like a pressure in his chest. He also has some tingling in his left lower extremity, no loss of bowel and bladder control, and his strength is intact. Any questions on that HPI so far? I wrote out the abbreviations for you so that way you guys would know. Okay, let's move on to his vitals and exam. So as you can see, his vital signs are all fairly normal. He's a little bit tachypneic at 22, but otherwise afebrile, normal blood pressure, normal heart rate. He's on room air, satting well. And this is the physical exam they took in the ER. So they say he has a regular rate and rhythm, his lungs are clear. He's got some pain on palpation of his anterior chest, as well as some midline T-spine tenderness and paraspinal tenderness to palpation. Otherwise, they say his neuro exam is intact, his lower extremity, strength and sensations intact, no saddle anesthesia. They got a couple studies, which I will show you, as well as his labs. So he got a chest x-ray. We have our PA and lateral. Take about 30 seconds with your tables, review the 2 chest x-rays, and then maybe I'll ask a med student from table 2 to give me their interpretation. Okay, so let's come back together. Table 2 here in the middle. Justin, do you want to take a chance at reading those 2 chest x-rays? You can always phone a friend for support if you need it.
I think that you see on the left, that's telling us it's an anterior posterior shot. So I was first looking at the heart, thinking it was a little bit large, but then remembering that that happens on the peak. I can't really see the airway very well from here.
Yeah, what's in the way of his airway?
Next, he's got some like hardware type stuff.
Yeah, perfect.
The lung fields look pretty good to me on the left side and the periphery. There might be some opacity there. And then I don't see any fusions or obvious fractures inside some EKG leads coming out.
Excellent. Anybody have anything else to add? Anything different to bring up? Okay, yeah, it's mostly normal chest x-ray except for his spinal hardware that he had surgery for. Okay, let's move on to his labs. So this is what the ER got in terms of his blood work. That creatinine is stable from prior, and he's a little bit leukopenic, which is also stable just given his bony involvement of his prostate cancer. His anemia is also stable. Any questions on the data that we have?
Baseline creatinine.
Yeah, he's at his baseline.
Oh. What's his allergy?
Not obtained. So that's all we got so far from the ER. What are you thinking about? Yep, to correct it. Yeah. Okay. All right. So they did all that. And then because of this pain that he was having, they also got a CT scan of his chest. I will loop this video so you guys can watch it twice. And then we will talk about the findings as well. It is a contrasted study. All right, and then one more time from the top. Purposefully not giving you his lung fields or his lung views because there's nothing going on there. Okay. Any upper level want to tell me what their thoughts are about this CT scan? I'll come back up to an earlier cut. So cancer patient coming in with chest pain, worse with inspiration, new onset. What's the one thing that you want to rule out? Yeah, new PE. Do you guys see a PE anywhere in those blood vessels?
You scroll slower.
Yeah, I can scroll slower. We'll take you through. I'll go backwards again. Anything major? Does he have a big saddle pulmonary emboli? No. Okay, give you guys the read. So they say no evidence of new metastatic disease in his chest. He has a known lateral right fifth rib lesion. He has a stable subpleural nodule. He has a pleural effusion that's resolved from prior. He has a stable hardware. And then even though it wasn't technically planned to be a PE study, they comment there's no PE to the proximal subsegmental arteries. Any questions on any of this so far? Okay, so the ER says, we've evaluated this guy, you know, he's coming in with his chest and back pain. We'd like to admit him for pain crisis. And so they call you. But what I want you guys to do is with your teams, talk about your differential, what are other things that we might think about in this patient presenting with worsening of his back pain. And if you want any specific test or another management step, let me know. We'll take about 2 minutes with your teams and then we'll go through each table. We'll start with Jace's table over there on the left and then work through each one. But come up with your top differential and what you want to do next for this guy as the admitting resident. I can, yeah. There you go. I think that we were there were no I think we ran out of spoons. Yeah. They're in the individual packages, so if someone's not using it, you can possibly take it from them. All right, about 30 more seconds. All right, so let's come back together, starting with table 1 with Jace's table. What did you guys talk about as possible differentials for this guy that the ER wants to admit for a pain crisis?
still on share.
Oh, I didn't realize we were table one. I thought-
Yeah. Your table one doesn't have to be anybody from your table can share.
Yes, we were talking about like some of the experience of like these rolled out, it's like new onset pain. We know he has like spinal mets, like sensory neuropathy, and it's kind of like dermatoma. Like you mentioned, C. I'm just really like sour. It's not really worried about like what I'm right now. There's like
Okay.
I think we would still on dedicated spine imaging to make sure there's not like any early core compression.
And what kind of spine imaging would you want? You have to be as specific as possible.
I would want like that MRI, got some lower extremity stuff, just kind of better things that probably scan the whole spine.
Okay, and then do you want contrast or no contrast?
What was it? You didn't have like fevers when you looked into it for infection, right?
Nope, no fevers, no chills, just worsening pain.
I want to do contrast.
Okay. Table 2, what's on your differential? That's right here in the middle.
Oh, wait, that's not- I take it back, it's metal.
He has metal, so now you want contrast? Okay. Or CT?
We can't MRI with it. I guess it depends on what he has.
Okay, so we gotta maybe investigate and figure out what exactly is inside of him, and then we'll do CT or MRI. Great.
CT myelogram.
We had talked about Mets too,
Mhm.
about the spinal stenosis,
Okay.
Pott's disease, essentially.
POTS disease, tell me about that.
TB.
Okay, what in his presentation argues for that or against it?
I don't remember. all
Okay.
his presentation, to be honest.
Okay, good idea, not missing anything. What do you guys want to do for your workup for him?
I guess we're on TV, that's done.
Okay,
We had also talked about MRI. Spinal compression, or metastases, et cetera, as well.
okay, and then what kind of MRI do you guys want?
Well, I heard there's my own more contrast. I think I just went, so I think I would go for that.
Okay, with contrast, MRI with contrast? And then what levels of the spine? All of them, some of them?
Should I start with lower, any of the lower back pain?
Chest pain. So back and chest pain. And then some lower extremity tingling. Okay, TNL. All right, last table, anything different?
We covered the same thing. The other thing we added on, was we added hardware in the spine, so like you could have like hardware could be infected, it could be failing, like abscess around that, something like that. So I think
Great,
CT scheme that you want to do a CT for us, but
okay. Great differentials. All right, so we will come back to the differential. We're going to take a look at the history that you get from him and your exam when you go down and talk to him. So first line is about the same. He's got this chest pain and numbness. He states that his chest and back pain that he's experiencing is like his usual pain that he deals with, only it's gotten worse to the point where he's helpless. It's not usual for him. If you guys remember, he's like helps people out in the gym. He's like a personal trainer. And so he had to ask his brother to come in and help him to bring him to the hospital. He has Oxy at home. He says it's not doing anything for his pain. The pain's primarily in his back, paraspinal muscles, and chest. And then he also says that he has numbness across his entire chest, starting at his nipple line. He says that this is new for him, came on about lunchtime the day before. And he says that he can't feel the skin on his stomach. He feels like his stomach is bloated. He can't feel much of the skin on his left leg. He can feel his penis and his scrotum. He's not had any issues with urinary loss or retention or stool incontinence. And then he describes the numbness, like when he's going to the dentist and getting Novocaine for a filling. He's not dropping anything. He's able to feel his hands. He had no trauma, no falls at home. He says he's not been eating very well because he feels nauseated. He does feel better now in that regard. And in the ER, he got a chest x-ray, a CAT scan, and then was given Valium for presumed muscle spasms. Questions on that? Does having this information change your differential or what you're worried about for this guy? No?
What was the question?
Does having this new information change your differential or what you're worried about for this guy?
Kind of sounded a little transverse myelitis too.
Okay, so maybe transverse myelitis, a cord issue itself. Any other thoughts? Okay, I'll give you the exam that the admitting resident took. So he's ill appearing, in distress. The neuro exam is what we'll focus on here. So he has intact strength, 5 out of 5, intact grip strength, but he has decreased sensation at his nipple line to his abdomen. And then he's numb completely down his left leg. His rectal tone is intact. Everything else is pretty much normal. So if you had to go back and pick one test from our list of proposed tests that we wrote down, what would be the one thing that you guys would want? Who's voting for CT of his spine? No one. Who wants more labs? Who wants an MRI? Everybody. What are you guys worried about? Transverse myelitis was one. Yeah, cord compression. What makes you worried about cord compression in this patient, Leila?
It's like a dermatome cutoff for numbness. That's pretty significant objectively.
Yeah.
It's hard when someone is pain limited in their like strength exam.
Mhm.
You can't actually objectively assess whether they have real lower extremity weakness.
Mhm.
And it's like a can't miss diagnosis against medical emergencies.
Excellent. So cord compression is a can't miss diagnosis. Leila, can I push you a little bit further? What kind of MRI do you want on this guy?
I would want a contrasted MRI.
Okay.
The guy with cancer might not reveal infection in the same way.
Great. I will give it to you. So I'm going to give you just one cut. We don't look at MRIs all that often. So this is a sagittal view. The spine is labeled here, so you guys can take a look at what level we're at. What level corresponds to the nipple line? Yeah, T4. So maybe pay more attention to that area. Let's zoom in, and again, I'll loop it for you. Want you guys watch once or twice more, and then we'll pause. Okay, so let's pause this video and come back a little bit. So, anybody see anything that is not normal or things that you have questions about?
Like a hyper intense speculated.
Can I have you point to it on the iPad? Ready? Let me just see. You can just draw a circle. What you're worried about. Great. Anybody else have anything that they're looking at? Or do you guys want some help from our radiologist? Take a look at the read.
Just a miscut, it looks like
Yep.
multiple kind of like eye lytic lesions, T12, T11, T10.
Yeah. So pointing out perhaps known metastatic disease already. So we know that it's in his bones and his lymph nodes. So picking up on that. Okay, I don't look at MRIs that often. So while I might scan through something, I still definitely rely on my radiologist to help me work through this. And so he got this MRI of his thoracic spine, and we're going to cut to the chase here. But the important thing to pick up when we're looking at his cord, so you guys picked up on, there was some sort of spinal issue going on. He has an epidural mass at T3, T4, which is causing severe compression of the underlying cord with edema. And he has tumor extension into his bilateral foramina, resulting in moderate to severe stenosis. Everything else is sort of stable. He has, his mets that are slightly increased from prior exams too, consistent with his new diagnosis of cord compression. So Leela, excellent job. Cord compression is a can't miss diagnosis. If the ER said, well, we already got a CAT scan and didn't look like anything, would you guys be okay with that? The answer is no. You always need to get the MRI and you need to get it with contrast to be able to see lesions in the spine. So it is okay to ask for more data from the ER before you admit someone if you're worried about that. Who here is taking care of a patient with cord compression in the past? Raise your hand. Okay. What is the one thing that you pay attention to when you're trying to figure out if this patient has cord compression or not?
Just one.
Or you can name a couple of things.
Okay.
I guess depending on the level, it's interesting to know like other motor neurons on signs and the species or something. Like the cauda equina, it's easy to focus on the vowel and letter, but obviously you can compress things.
Yeah, and what other motor neuron signs are you specifically going to ask about or examine?
Reflexes and movements.
Okay. Anybody check anything else?
One thing we have is a patient right now with like cervical compression, and one thing we talk about is like whether it's edema or not, as like indications for like lung surgery or like steroids.
Yeah.
Like around the, on the MRI reading.
Okay, so jumping ahead to treatment. I think the one thing that we're taught is you ask people if they have bowel or bladder incontinence, and you're like, I figured out if they have cord compression or not. But that is only at the level of the cauda equina. And so you guys have to remember that the spine runs all the way up and down our bodies. And so the thing that most patients will actually complain of is not loss of function, but pain. So if a patient with cancer, known cancer especially, is complaining of focal pain, often if it's worse at night, people tend to think that there's some variation in like our natural steroid production in our body. And so that's why they often experience worsening pain at night. Then you should be thinking about that. Sensory loss is another common symptom. So most tumors will start in the anterior portion of the spine and grow backwards, which is why sensory loss is one of the first things to happen. And then the motor issues that we talk about, so loss of strength, ataxia, spinal instability, are late findings in patients who have cord compression. So when you guys have a patient with cancer or suspect cancer, think about this as the presenting sign. And now that we know that he has cord compression, as Leila mentioned, this is an oncologic emergency. So what are we going to do to treat him?
Steroids.
Steroids. What kind? How much? How do you want to give it?
Dexamethasone, 4 mg Q6.
Okay, excellent. That's coming from some data. Anybody have anything different they would do? Yeah, start with 10. So you guys are both correct. So when we start off, you want to give them dexamethasone, 10 milligrams IV times 1. And then you're going to give them 4 milligrams every 6 hours until definitive treatment can be obtained. Most patients will stay on IV because you want them to absorb. And if anything else is going on, you don't want to mess around with them not absorbing their steroid. Okay, and then once we give them their dexamethasone, what's the other thing that we have to do to provide them with definitive treatment? Here, Josh is holding up a phone. We're going to call someone. So who are the people that we're going to call, and what is our question to them going to be? Okay, so we have our surgeons. There's another group of people that we can call. Yeah, do you guys know how to, like, who to call in what situations? Yeah.
And all situations.
Great answer. So calling both. So the way that I generally think about cord compression in terms of my consultants is the spine stable or not? And stability is not just like, are they able to stand up and move around? It actually gets down to exactly how much of the cord is being affected. And so if there's any invasion into the cord, like this guy had severe cord compression, it's considered unstable. You want to call surgery first because usually they'll do a decompressive surgery and then the patient will get radiation therapy. So both parties need to be involved. If the spine is stable, if the tumor itself is not extending into the cord, then oftentimes they can get away with just radiation. Obviously, you have to talk to your surgeons because the patient may or may not be a surgical candidate based on their expected life expectancy and other complications. But yes, calling both radiation oncology and surgery, which is usually ortho or neurosurgery, depending on who's covering for the day, is a very appropriate move. So take the next about 1 minute and talk with your teams about the other things that we should be doing for patients who have new cord compression. So we're going to start them on these high dose steroids. We're going to call our consultants. But then I want you guys to spend some time thinking about, is there anything else I need to do for this patient who's going to be getting this sort of treatment? Take about 1 minute, okay? And then we'll start here with the third table and work our way down. Okay. Table 3, what do you guys want to do for this guy aside from giving him his dexamethasone and then calling Radonc and our surgeons?
So talk about stabilizing the spinal cord. So there's a dose and that also trying to manage his pain.
Okay, perfect. So just making sure his spine is stable, managing his pain. Table 2, anything else that you guys want to do to help manage this patient? Okay, well, yeah, we'll do the same things. Anything else that you want to add? Okay, table 1.
Probably admit to a unit that can be frequent neuro checks until
Yeah, great. So neuro checks, making sure things aren't getting worse or changing. Are you guys gonna, give him his dinner tray and let him chow down on this sloppy Joe that the VA has provided? No, right? So he might need surgery. We don't want to jeopardize his chances of going to the OR safely. So things that we should think about doing, giving him his high dose glucocorticoids, making sure we're monitoring his bowel and bladder function or his sensory function, just like David mentioned, with frequent neuro checks, keeping him NPO, making sure he has good pain control, and then calling our consultants early. So it is an emergency. Don't hesitate to call them. They will ask for that MRI if you're worried about it. And you can always say the MRI is ordered. He's going down right now, but I want you to come see him first. In terms of spine stabilization, people often think like, oh, do I have to make them on like bed rest only or like not allowed to move around their room? And that's usually not the case. So these patients usually know their limit of like how far they can go before the pain gets too bad. And so you can still have them being mobile and up in their room. In terms of DVT prophylaxis, you want to make sure that you talk to your consultant because he obviously has cancer, high risk for DVT. But if he's going to the OR that night, they might tell you to hold off until they evaluate him. So just make sure you check in with them early. Questions on this? Okay, I think I heard someone talking about, oh, he's going to be on high dose steroids. We should check his blood sugars when you guys were discussing. Someone say that? Yeah, so this guy's going to be in high dose steroids. What are some things that we have to think about or monitor for when we're starting patients on big doses of steroids?
So if it's chronic, then you get two prophylaxis for like infection there.
Yeah.
And opposite high dose doses.
Okay, perfect. So monitoring his blood sugars, maybe thinking about PCP prophylaxis, anything else that you guys think of when somebody is started on high dose steroids?
Status.
Okay, so monitoring their neuro exam and their mentation. Bleeding risk, tell me more about that.
That's all I got.
Okay. And then one more thing that I usually think about. Not leukocytosis.
PPI.
PPI kind of goes with bleeding. So another complication of starting a high dose steroid. Usually doesn't happen for a while if they're on it for a long time. Yeah, osteoporosis. So let's talk about these complications. So You know, for all intents and purposes, if this guy was on steroids for like 1 day and then got decompressive surgery and they said no more steroids, we wouldn't have to worry about this. But we know sometimes that when patients are getting radiation therapy, it can take weeks for their radiation therapy to be completed, and they stay on steroids during that process. So these patients with cord compression can end up on steroids for a decent amount of time for their treatment. So we have to think about osteoporosis prevention, GI prophylaxis, and PCP prophylaxis for these guys. We'll save diabetes for another talk, but you're totally correct that if somebody has diabetes, it can exacerbate their blood sugars. So anybody have any thoughts about what we do for osteoporosis prevention, or when we think about preventing osteoporosis in patients who are on high-dose steroids? Okay, so maybe a bisphosphonate. Any other thoughts? Who needs osteoporosis prevention for those patients that are on high-dose steroids? I might not be asking this very well, but if they're on it for 2 weeks, do they need osteoporosis prevention? If they're on it for 3 months? Yeah, so there's like maybe a time component in there of like when we consider it. Let's chat about some data. So for osteoporosis, the American College of Rheumatology, let me get this back normal, ACR recommends vitamin D and calcium supplementation for any patient who's going to be on glucocorticoids for greater than 3 months. And so the dose that we normally think about for calcium is 1,000 to 1,200 milligrams a day. And then for vitamin D, it's 600 to 800 international units per day. And you know, this is presumably if the patient can get it from their diet, you can definitely feel free to have them just eat and get their calcium and vitamin D replaced. But if somebody has poor nutritional status or you're worried about them not meeting those goals, you should give them a calcium and vitamin D prescription for that. If a patient already has decreased calcium levels, maybe some osteopenia, what you can do is calculate their FRAX score. And depending on what their percentage risk comes back as, they may or may not be eligible for bisphosphonate dosing to help prevent osteoporosis if they're on high dose glucocorticoids going forward. A Cochrane review looked at, you know, is giving patients vitamin D and calcium even worthwhile? Does it cause a difference? And we know that the weighted average of bone mineral density in these patients for their lumbar and radial bones was higher in the patients who received vitamin E and calcium supplementation compared to those who did not. So we have actual evidence that their bones were healthier if they got the supplementation. So that's why you often see patients on this who are going to be on steroids for a while. Do we know how long this guy's going to be on steroids? No, right? Like you're admitting him or you're the resident who takes over the next day. And so it is a low risk intervention to put somebody on calcium and vitamin D. You know, his calcium corrected with his albumin. It was a little bit high when he came in, but they corrected to normal. And so preventing a fracture in the patient is of the utmost importance. So I would actually just say you should start them on it unless they have a contraindication like hypercalcemia. Questions on that? Okay, and then we talked a little about bleeding. So what patients on glucocorticoids need a PPI or some sort of acid suppression? What was that?
If they're not eating.
If they're not eating?
Yeah.
Okay, any other things that get you guys worried? Not necessarily. What if I told you they're on, go ahead. So what if they're on, you know, like ibuprofen 800 Q8 hours for their terrible osteoarthritis? Do they need some protection? So for bleeding risk, a lot of it comes down to what is their past medical history. So do they have a history of peptic ulcer disease? Do they have medications that we need to watch out for? So like NSAID use or anticoagulant use. If they do, then, you know, I would definitely put them on a PPI at least once a day during treatment with their high dose steroid. And so we know from the literature that people on steroids alone have a slightly increased risk of bleeding, 1.1 to 1.5 relative risk compared to those who are not on it. And if you have somebody who's on steroids and an NSAID, their risk of bleeding goes up to 2 times that of those who are on nothing. So if you have a patient who meets any of those criteria, so like prior history of PUD, prior history of gastritis, or is on an NSAID or other antiplatelet or anticoagulant, consider giving them a PPI while they're on their high-dose steroids. Okay, last one we have to get to is PCP prophylaxis. So what do you guys know, or what do you guys think about that for patients who are on high-dose steroids?
It's like if you take 20 days, like we're in 2 weeks, or 3 weeks or something, then it's an additional recommended to start.
Yeah, great. Any other thoughts from anybody? Okay. Yes, so if somebody is on 20 milligram equivalents of prednisone a day for greater than 4 weeks, usually, we talk about starting PCP prophylaxis. So this is, any patient. In the past, we talked a lot about patients who had HIV or AIDS, making sure that they especially get on PCP prophylaxis, whether or not they're on steroids. But other patients that you guys should think of putting on prophylaxis would be anybody with a blood cancer or a stem cell transplant. Their blood cells are not normal. They're not making a normal immune system, so therefore they need extra protection as well. And then other patients that we often don't think about are rheumatology patients, if they're on immunosuppressing drugs, patients who might have ulcerative colitis and are on TNF alpha agents should also get it, and then any solid organ transplant patients. What do you guys think about patients who have solid tumors and not blood-based cancers? Do they still fall into this category of needing prophylaxis? Okay, we got to vote for no. Anybody else vote no? Raise your hand. Who says yes? Okay, the data is actually not great about solid tumor patients. So in the past, definitely the people with HIV, people with blood-based cancers were in the main trials, and like the data, retrospective data that we had looking at PCP prophylaxis and people on steroids. But we do have some data coming out now that can inform us a little bit about it. So MD Anderson published a study. They're the first paper that you guys see there. And what they did was retrospectively go back and look at all of their patients who had any sort of malignancy and had PCP pneumonia. And they found that about, I believe it was 20 to 30% of solid tumor patients, of the patients who had PCP were solid tumor patients. And then there's a Cochrane review as well that says that the number needed to treat to prevent PCP pneumonia in one solid tumor patient was 19. So fairly low number needed to treat. Lastly, the paper at the bottom is some research that I've done with my research mentor. And we've taken care of a bunch of patients who have solid tumor diagnoses, in particular prostate cancer, which this patient had, who ended up on high-dose steroids for cord compression with their radiation treatment, who ended up getting PCP pneumonia. And there are not any retrospective trials looking at putting patients on it or not, but I would recommend that there is some data in the literature that reflects that people with solid tumors, their actual cancer biology can affect how their immune system is functioning. And so if you don't know when a patient's going to be taken off of their high-dose steroids, and it's better to put them on PCP prophylaxis that can then be tapered by radiation oncology or their primary oncologist in the outpatient setting. Because if they get PCP pneumonia, it's typically not a great outcome for somebody who's already immunosuppressed. So that we've talked a lot about who gets PCP prophylaxis, take about 30 seconds with your table and try and come up with all of the different regimens that we have for PCP prophylaxis in people who are on high-dose steroids.
Yeah.
What is it? Oh, yeah.
Okay, let's start with, we'll start with table 1, and then if you guys can give me each one answer, we'll sort of figure them all out together. So table 1, what would be the first thing that you think of for PCP prophylaxis? Okay, spectrum. Bonus points if you know the strength of the tablet and how often they would get it. Yeah, no worries. Table 2, what would be another option that we have for PCP prophylaxis?
Yeah, so.
Okay, great. Dapsone, what do we have to think about or check for in a patient who started on Dapsone?
I guess open draft.
Something else that we think about. A hemolytic anemia could be caused if they have what? Yeah, G6PD deficiency. So you check a G6PD level. Table 3, any other options that you guys know of? Atovaquone, great. Come back to table 1. Anything else that you guys know of? You can say no. Something else? Okay, so there's one more. Let's pull up the treatment regimens. And so a couple different regimens that you guys can think of. So Bactrim, one double strength tablet 3 times weekly. If they have a self-allergy, they can't really get that. You can think about Dapsone. You need to check a G6PD level to make sure they're not deficient before you start it. Atovaquone is like this highlighter yellow. I'll make it bigger for you. It's like this highlighter yellow liquid that comes in a tube, and patients will say it tastes very bad. And also it's fairly expensive for most patients that I've taken care of. Their insurance won't cover all of it. And so it ends up not being a great option for most people. And then lastly, inhaled pentamidine. So if they can't take any of the others for any reason, they can actually take it in inhaled form. The trouble there is remembering to dose it every month and making sure they don't miss it in the outpatient setting. Okay, so today we talked about a patient admitted with cord compression. We talked about how the most sensitive question to ask is about worsening pain, and then thinking about sensory deficits, and then like severe motor deficits coming later. We talked about the 3 things that you guys definitely need to remember when somebody's starting high-dose glucocorticoid therapy. So osteoporosis prevention, GI bleeding prevention, and then infectious prevention. And then we talked lastly about calling consultants for radiation therapy versus surgery, and then medication regimens for PCP prophylaxis in these patients. Any questions at all on anything that we covered today? Okay, tomorrow we'll have another case conference. You'll notice a theme throughout this week that steroids will find their way into conference. So we'll be talking a lot about that. Otherwise, Thursday, Renal will give a lecture. Friday, Jason is covering. So lots of good conferences for you guys. The candy is refilled in the chief office, so stop by and get some if you'd like it. I will unfortunately not be here this afternoon because I have clinic, but if you have any issues that come up, just email me. If there's any other computer issues or like signing medication issues, just send me an email. I can get that fixed for you. Okay, thanks everybody.